Tonight, we begin our 21st season with our viewers' favorite show, Ask the Prairie Docs. All 4 Prairie Doc hosts will be in the studio this evening. Stay tuned and join us for the next hour as we continue to provide medical information based on science, built on trust. Good evening and welcome to the 21st season of On Call with the Prairie Doc. Medical information based on science, built on trust. Thank you for joining us. During this episode, we will be answering viewer questions about any medical topic. I'm Dr. Kelly Evans-Hullinger, your Prairie Doc host tonight. Joining us in the studio are Prairie Doc's Dr. Deb Johnston and Dr. Andrew Ellsworth of Avera Medical Group Brookings, and Dr. Kruse, Dr. Jill Kruse from Brookings Health Systems. Welcome back, everyone.
Yes.
It's great to be in the studio again.
Nice
to see you.
4 of the Prairie Docs,
Yes.
all here. So
not always easy to do.
No.
I think we're gonna have no shortage of questions, and so I think it's gonna be a great show. Let's do like a brief introduction. Maybe it's been a while, maybe we've got some new viewers. Dr. Kruse, do you wanna start? What do you do?
All right, so I'm a hospitalist now. So that's as of, we're coming up on my 1-year anniversary of working primarily at Brookings Health System, taking care of inpatients while they're there. Still do show up at the clinic every once in a while just to keep doing my flight physicals and some urgent care issues, but been here, it's coming up on my 9th anniversary here in Brookings, so it doesn't seem possible, but my daughter just turned 10 and she turned 1 like the month we moved to Brookings, so.
Yeah. And you busted right over here from the hospital. Busy
yes,
service,
I'm still in my
as
work
such.
clothes.
Thank you for being here.
Thank you to Dr. Suni, who graciously accepted taking over an hour early.
Awesome. Dr. Johnston, tell us about yourself. What do you do?
So I'm a family medicine physician, and I have been in Brookings for a very long time, since 96, as a matter of fact. Lose track, it's been so long. And I do primary care at the Avera Brookings Clinic, Access Health.
Yeah, great.
Yeah.
Dr. Ellsworth.
I'm Andrew Ellsworth, a family doc, just like Deb. Been here 10 years now, and so been in Brookings for 10 years, and I've got a lovely wife and 2 children.
Awesome. Well, I'm happy to be here with you guys, my friends. We have some questions that we can maybe get started on, but just so our viewers know, tonight on Ask the Prairie Docs, we invite you to submit or call in with your medical questions. Your name will remain anonymous, but please call us in 3 ways. You can call 1-888-376-6225, send an email to ask@prairiedoc.org, or message us on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible during this episode. Sometimes we do receive more questions than we can cover, and we apologize if we do not get to your question. But to encourage you to ask early, all questions asked in the first 20 minutes will be entered into a drawing for one of our Prairie Doc gift items. The winner will be announced at the end of the program. Your question will remain anonymous, but please provide contact information when you submit your question. And it looks like we've already got some. So shall we dive in?
Let's do it.
Let's start with a kind of a hot topic. New COVID booster that maybe is specific to the Omicron variant, which has been our dominant variant now for months and months. We've been speculating about this for a while, but there's news out just today in the last 24 hours. What do we know, Deb? What can we tell patients? What are we still waiting to learn?
So the vaccine has been approved by, or recommended, I guess I should say, by the Vaccine Advisory Committee. So now it has one more step. The director of the CDC needs to sign off on it, and then it will be available for distribution. So my understanding is that we should be able to be getting those shots in arms very shortly after she makes that final decision, assuming that she does approve it, which I think we're all kind of taking on faith that she probably will. So within the next couple of weeks, we should be able to start getting those shots in the arms. What I have read is that they are saying that you don't have to have a long time from your last booster before you can get this new booster. One of the questions that people have had, where they've read, well, gee, this one hasn't been tested the way the old one was. It's important to remember how this vaccine works compared to how a traditional vaccine works. So this vaccine uses a little segment of mRNA that they can create to make it make anything. So all they had to do was tweak that little mRNA, tweak the blueprint. Everything else is in place. It's like plugging in something different to your 3D printer. You've got your 3D printer knows what to do, you just put in a little different instruction. So now this vaccine is going to help protect against both the original strain and 2 variants of the Omicron strain that we're currently seeing so much of. We do this every year, people with the flu shot. Yeah. We create a vaccine that, it's a different vaccine technology, but every year we're trying to guess what the dominant strain is going to be. They don't run that new vaccine through human trials every time. They check and see, hey, how does it affect our antibody levels? So there's no real reason to think this vaccine's not going to be as safe as the original vaccine. Will we get the same kind of protection that we're hoping? Well, if we wait until we have that answer, we're going to have another variant around by then. So get it when you're eligible for it, people. I can't wait. Yeah. I can't wait.
It's just as new as to not tested on humans or whatever, just like an annual flu shot is.
Yes,
exactly. There's very little that's different about it from the other mRNA vaccines, which most people have had several doses of at this point. So,
but the beauty with the mRNA technology is that we can update it faster than we ever could with the old flu shots.
Right,
so.
Which has gotten us into a lot of trouble with the old flu shots, with years where the virus didn't grow and so we had a real vaccine shortage, years where they totally missed, because every year they're guessing what strains are going to be dominant. And I'm excited about what this mRNA technology is going to mean for vaccines in the future. It's really exciting.
But even in years where they don't guess the flu shot quite right, it still
get it.
Still cuts down on your risk of hospitalization big time. You might still get it, but it decreases the risk of a severe case, just like the COVID shot decreases the risk of a severe case. You might still get COVID, but it'll be more mild.
Right, and as a hospitalist, I can say firsthand, I am seeing more COVID hospitalizations again. It kind of tapered off and slowed down. I'm like, oh, phew, we're out of the woods. And all of a sudden, the last 2 weeks, I've been admitting more COVID patients again.
Yeah, so numbers have been high at the end of the summer.
They've been very high.
Yes.
Timely because it's flu shot season coming right up again. I've seen signs at a pharmacy already. What can we tell people, Andrew, about flu shots as we're also rolling out this new COVID vaccine? Are we going to need to spread them out? What should we be doing?
You can go ahead and get them at the same time.
You bet.
If you want to space them out, you can.
Yeah.
Or if you only want them a day apart or a week apart, you can. Or on the same day, it's okay.
Yeah. Yeah.
And we've done that.
Right.
We did that last year.
Yeah. Good. Okay, we're just going to dive in. We could have anything come up here. Let's start with this first question. Is there any new research on the benefits or harms of coffee? I love this question because I love having my bad habits validated for me.
As our resident coffee drinker,
Deb.
Well, what I tell my patients about coffee: does it keep you awake? No. Does it make you anxious? No. Does it upset your stomach? No. Drink your coffee. Right. There are some people who are very sensitive, some people who have problems with coffee, but for most people, you can drink your coffee. And I think I had read something recently about new research, but
I think every other year there's a new big, retrospective study about coffee, and the latest one was positive, probably increases longevity, but only if it's black. If you're drinking it with a bunch of sugar and cream, that probably takes away any possible benefit.
Yes.
But if you're drinking black coffee and keeping it to a reasonable amount, probably okay.
When I picture my grandparents in the church basement drinking coffee, it was black coffee and pretty weak too. But
I'm not sure I'd call that coffee, Andrew. My church basement was colored water, so.
but that was okay. They did well with that. But when you're adding a whole bunch of cream and sugar and stuff, it's probably giving you more calories than you need. And for some people, it's keeping them up at night, and they should only have it in the morning or something. And for some people, it's giving them adding to reflux and heartburn and stuff, and they should maybe peel it back some. But everything in moderation.
Yes.
Good. We have a question from a healthy 27-year-old male who only sees. Yes, thank you.
27-year-old male calling.
This person only sees acute care providers when needed. Do you suggest seeing a primary care provider for a healthy young person like this, and if so, why? Andrew, what would you say to this person?
You know, it's a common story, and then, but when we can get them in with a regular doctor that they know they can turn to for things, and a preventative physical, where you find, oh, you need a new tetanus shot, and oh, actually, given your family history, we should be checking your cholesterol or screening for colon cancer or prostate cancer or breast cancer, and not in the male, but
Although men
males can get it.
breast cancer.
Yes. So we really tease out the family history to find out what tests we need to do, get some shots updated. There's always something that really comes out of benefit of those visits. So.
And honestly, one of my I really like doing preventative care, and those 27-year-olds, that is a great time to be talking about, hey, especially in the women, are you drinking milk? Or where are you getting your calcium? Are you wearing your seatbelt? Are you texting and driving? You know, all of those kinds of preventative things, a lot of which pay their dividends much later in life. So if you wait until you're 65 to come in and hear, what's your calcium intake like? You know, we're doing damage control at best at that point. If we can get those 27-year-olds leading that healthy lifestyle, it pays off those dividends later on. So absolutely, there is value.
Thank you for asking.
And
Strong yes from this group.
Sometimes we find, oh, your blood sugar is just a little high. Well, now you're young enough. Again, you can change those habits so that you don't wait till you're a full-blown diabetes.
Or your blood pressure's borderline, and there's a strong family history with that. I mean, it's always a very good thing, and I find those males, you know, I would say high school till about late 20s, early 30s, until they have a wife that brings them in or they start having kids, they kind of drop off. I mean, when you're no longer getting sports physicals for school or for college, you know, we kind of lose that demographic, which is unfortunate because there's so much, again, with stress and mental health issues to be talking about. You know, there's a lot of things. You don't want to establish a relationship with the primary care doctor because I referred you because you were in the hospital with something. So that's not the best way to find a primary care doctor, is because something got bad enough you needed to be in the hospital, and now I'm referring you to a primary doc.
All right. We got questions galore. Let's keep going. My hands are stiff when I wake up each morning. Is this anything to worry about? Jill, you want to start with that one?
Well, I would say, again, talking about age, what have you been doing? Are you someone working at 3M doing a repetitive job every day? Is that something, could it be an overuse injury? Is there a family history of rheumatoid arthritis? That would be the thing I would worry about. Morning stiffness, especially in fingers and hands. That could be an early sign that someone could be developing rheumatoid arthritis. So I would definitely get it checked out.
It's worth asking. Agreed. All right, how about this one? I had cataract surgery a year ago and continue to have double halos. Is there anything that can be done to correct that? Deb?
It depends on the cause of it. That is a difficult one. Sometimes people will develop kind of a pacification of the posterior skin. It's not really skin, but think of it that way, to where the original lens sits. And sometimes that's something that can be treated. Sometimes it has more to do with the implanted lens. That's definitely a work with your eye doctor kind of thing.
Yeah.
Or watch the eye show in January.
Yeah, there you go. And you ask that question again.
Okay, we have a question from an adult male who is uncircumcised and is now having trouble urinating. Andrew, what would you advise?
Yeah, that can happen. I'd recommend they come in, because you need to be able to urinate, or that can be an emergency. And that can happen, and where it can get blocked. And so sometimes we do have to have men get circumcised later in life for that reason, for infections or blockages or strictures if it's pinching it and stuff. So
the other thing, we don't know how old this individual is, so it may have nothing to do with his circumcision status, the fact that he's having trouble urinating.
Yeah.
So it's definitely a come in, get it checked out, get it, whatever it's causing it, get it fixed.
Great. The REACH mentorship program is focused on helping disadvantaged high school students gain access to graduate school learning and medical opportunities. Prairie Doc reporter Sam Schauer has details.
REACH, or Relationships, Engagement, Awareness, Collaboration, and Help, was founded by a group of medical students at the University of South Dakota Sanford School of Medicine in the fall of 2020. Ashley Durant, a senior medical student, is one of the founders of the program and recognized a need to connect underserved high school students with the benefits of graduate-level work.
Historically, minorities don't have as many opportunities to get into really graduate programs like medical school and things. And so we just wanted to really do something to help foster those relationships and really encourage some students that deserve to be in programs such as medical school, and offer some guidance for some people that might not have as many resources as some others might have.
High school student mentees are paired with medical student mentors through an application process.
So both the mentor and the mentee apply, and the application is really just to get an idea of what each person is about, what their background is, what's important to them.
One of those mentors is Megan Grossel, who has been a part of the REACH mentorship program for 2 years.
My friend Ashley had started working with the program, and they reached out looking for other mentors to help people wanting to pursue medicine as a career, and that spoke to me, and so I signed up.
Mentors provide valuable insight about what to expect in medical school and answer questions from their mentees.
So during the program, we meet at least once a month and discuss topics that we kind of pre-designed to make sure that we cover the important things. So we start with applying to college and things like that. And then we move up through the process of medical school and becoming a doctor, and give people information that is straight from the source instead of through Google.
The success of REACH has led to thoughts of expansion to other medical programs.
We've had great success. We've had some phenomenal matches and lots of positive feedback. And we're really hoping to expand the program more in the future to include other health professional programs beyond just medical students. So, for students that might be interested in nursing, trying to connect them with nursing students, or like a PA program, physician assistant program, or like physical therapy, those sorts of things.
Overall, the REACH mentorship program has proven to be successful, with many opportunities for growth and continued impact in the years ahead.
They are genuinely so excited to be here and so excited to pass on their knowledge and their experience. And I just think, we have this wealth of, information and excitement and energy. And so being able to put all of that into a great place and offer some of these high school students some mentorship is just, it's a phenomenal opportunity for all parties.
Thanks for that, Sam. What a great program. Awesome. We're going to get straight back to the questions. We've got a lot of them. So let's start with one about an umbilical hernia. Jill, we have a caller who has one of those and wondering, should they have surgery? What makes surgery necessary in an umbilical hernia? And is it something that they should deal with sooner rather than later? Or what do you think about that?
So What a hernia is basically there's an opening where either fat or intestine can get through kind of that muscle and fascia layer and it pop out. And belly button's kind of a weak point where that can happen. It's not a big deal if it's fat and stuff that can kind of go in and out of the hole. I always say the problem is not the hole, it's problem if intestine gets in that hole and gets trapped. And if it gets squeezed, pinched off, it can lose its blood supply, it can become necrotic and die, and that becomes a surgical emergency. If it's going in and out, no big deal. Actually, usually the larger the hernia, the less likely they are to cause a problem. So big ones, you could drive a truck through, in and out, nothing's gonna get stuck. Tiny ones, something can get wedged in there, and that would be a problem. So if it's causing pain, if it seems like it's popped out and you can't push it back in easily, then I would definitely talk about getting that surgically repaired. Like I said, if it's out, you can't get it to go back in, especially with laying down, relaxing. That definitely would be a sooner rather than later emergency to get checked out.
Right. Not all need surgery, though.
Not all need surgery, though.
Yeah. Sometimes I just send them for a consult and they can learn about their options depending on how much it's bothering them. But okay, great. What do we recommend for medications for seasonal allergies, Deb?
That is such a tough one. So first step is usually a non-sedating antihistamine. These are available over the counter, something like Zyrtec, Xyzal, Allegra, Claritin, and their generics. Things like Benadryl, chlortrimeton, the old allergy medicines, I do not recommend those because they are sedating. You can have car accidents the next day even though you think you're fine. Those are the secret ingredients in Tylenol PM and those things. They are not a good thing to be taking. The nasal steroids are another great option over the counter. It's important to use them correctly. Point towards the back of the head, not up between the eyes. Use opposite hand so you don't spray on the septum. Remember, those do not kick in right away, so you've got to use those for a period of time. Then there are some prescription options. People can get allergy shots. The allergists have some other fancier things they can do, but for the vast majority of people, those things combined with maybe nasal saline irrigation to wash those allergens and irritants out, and some local control. Keep the cat out of the bedroom if you're allergic to the cat. Those things are sufficient for most people.
Yeah, great. Let's see, we've got a caller from Sioux Falls who has a light case of peripheral arterial disease and is wondering if there are exercises or medication to improve it. Andrew, what would you tell this person?
Yeah,
what is peripheral arterial disease?
When the blood flow and wherever is getting blocked, in the arteries getting blocked or decreased, partly blocked. The short answer is exercise, walk. Walk has been shown to help. It can help increase the blood flow. Also, quit smoking, and then watch your blood pressure and your cholesterol, and eat healthy, and get diabetes under control. But sometimes, so sometimes they'll do some medications. Sometimes they'll do surgery. But basically, if it's a light case and they've haven't said you need any medicines or surgery, the best thing is to exercise and walk.
Yeah, exercise, great. Like most conditions in which there's plaque in an artery, we usually would recommend a baby aspirin. A lot of these people we will put on a statin medication, but it may depend on other factors for this person too. So, all right, we've got a caller wondering whether or not a known side effect of the COVID-19 vaccination is ringing in the ear. Jill, have you heard of that?
I haven't heard that.
Agreed. Common with viral infections on the other hand. Anyone have anything on that? Ringing in the ear is so common that probably a coincidence. But
very, very common problem that we get on this show a lot too. And
hard to treat. Yeah. We have a caller from Wessington Springs whose daughter gets a persistent red rash on her cheeks and wondering what she might try to do to treat it. Is there anything that causes a pediatric
the first
rash
thing
like
I
that?
think about in this case is eczema. This might be a child with atopic dermatitis, and especially it sounds like this is kind of a chronic recurrent problem, maybe itchy, maybe stinging. The big thing, gentle cleanser, and also hydration. So a lot of lotion, a lot of moisturizers, and maybe if that's not doing it, go in and see the doctor and see if there's a need for some prescription medications.
Yeah, good. We talked a little bit about the COVID vaccine. We have a caller who waited to get the third dose, the booster, and asking if they should go ahead and get the booster now or wait for the next shot. What would you say now, Andrew?
Yeah, I mean, at this point, we're really close to getting the new shot, so I've started telling my patients, go ahead and wait. But you can get your other booster now.
Right.
But at this point, if you need to only wait a couple weeks, then maybe just do that.
Okay.
And some of that might depend on how high risk you are too.
Yeah. If you're going to travel in 2 weeks, maybe you want to get
because
your other booster
it does
now.
take about 2 weeks for that booster effect to hit. If you're a high risk individual, if you've got a high risk situation, you may want to get the old one now and get the new one as soon as you're eligible.
Good. Another COVID question. We have a caller from Sioux Falls wondering what medical information is available regarding long-term effects for a person who had a severe case of COVID-19. This person was hospitalized for 3 weeks. So what kind of things do we see in those patients longer term, Jill?
So there have been like some chronic fatigue issues, or they're really tired, having a hard time getting their exercise tolerance back. We've seen heart issues, atrial fibrillation I've seen with patients with COVID, higher risk for like congestive heart failure. So we are seeing kind of cardiac issues and just stamina.
Yeah.
And prolonged smell and taste, loss of smell and taste that is prolonged, and kind of a chronic fatigue is what we've been seeing a lot of.
Which can be really incapacitating and disabling. And I think we're going to learn a lot about those long-term viral things. Chronic fatigue syndrome, was present before COVID and really difficult to identify and treat. So there's a lot of research, there's not a lot we know yet, but it can be really devastating, and that's why you need to get your shot.
But I wouldn't lose hope that it might go away and get better. I mean, we do see those cases gradually improve,
unpredictable.
Typically, but it's
and
unpredictable.
some may be very slowly improving. I had a patient with a very severe case who left the hospital, I think, on 10 liters of oxygen, and he, a year later, was off oxygen. It just took a lot of time for his lungs to heal. So. Okay, we got a caller with a persistent head itch that has not gotten better despite changes in shampoo and other treatment. What would you recommend for someone like that, Andrew?
I mean, if there's clear dandruff and stuff, if you haven't tried a dandruff shampoo, that'd probably be a good place to start. Now, you might want to get it looked at because there could be, you can get skin cancer on your head too, and that could be itchy. Or maybe you'll need a steroid cream prescription or something else to help, but it depends on how it looks, or maybe it's a fungal type infection, and so it good reason to get it looked at.
Yeah, or just overactive nerves. Sometimes we find nothing on the skin and people have itchy scalps, but get it looked at if you haven't yet. We have a caller from Sioux Falls who recently had an operation on her carotid artery and complains of tightness in that area. She's wondering if there's a reason for this, or what might you advise a person like that, Jill?
So it could be, some people can develop what's called a keloid, where it's kind of an overgrowth of a scar where it just gets really tight. So I would talk to her surgeon, or his or her surgeon afterwards. There is some stuff that physical therapy can do. I've seen patients, if they get bad keloids, that plastic surgery can inject them to get that, and some gentle stretching. Now, it's over the carotid, so you're not going to be messing with it until you're like cleared by a doctor to do that, or a therapist. But if it is feeling tight, know that as that healing process happens, the skin's going to contract, and then it's going to take a while for it to stretch back out. So it's probably in that healing contraction phase of the healing process, and that's probably why it feels tight.
Probably don't do super aggressive
I would not
massage
be
or anything
super aggressive
right after you've
massaging, no.
had that
Let it heal
carotid
first.
surgery. Okay. We have a caller from Volga who asks, can you get secondhand smoke from someone who is vaping, secondhand vaping injury? If so, what caution would you take if you're around someone who's vaping? Deb, do we know the answer to this?
I don't know an answer
I
to
don't
that.
either.
I don't think that there's a lot of the same kinds of secondary inhalation issues that there is with cigarette smoke, but I would put in a plug for quitting vaping in the first place. It's still not good for you.
Yeah.
There's a lot of chemicals in there that we just don't know about, and that maybe it wasn't in there, but once it's heated, it changes some chemicals, especially if you're putting in flavors or mixing things or something and heating it up. What is that turning into? And then what is that putting in the air then too? So there's a lot of unknowns yet with vaping.
Same caller asked, how long do blood clots in the lung take away to go on their own? Jill?
Don't do that. Don't do that.
Usually when we have people with pulmonary embolisms, we will have them on blood thinners for several months, and some people indefinitely. So the blood thinners, the idea is about stabilizing them so they don't continue to grow and they don't get bigger and break off and cause more problems in other areas. So, we generally don't scan to see if they're cured or scan to see if they're gone. So it'd be hard to say an exact time, but it'd be a minimum of 6 months on a blood thinner.
Yeah.
So usually a year.
That's what I tell people too, is that the blood thinners don't actually get rid of the clot.
Right.
They keep new clot from forming, and it probably does take that 3 to 6 months for your body to break down that
and
clot
reabsorb
that's formed.
That's
Depends
while
how big
you're
it
on
is.
a blood thinner to keep it from getting bigger. So if you're
Right.
not on your own, it could keep getting bigger.
Now, there are medications that we will use in the hospital in severe blood clots to dissolve that clot, but that's a different situation than most people.
Or the exception than the rule.
very
That's
much
for
the
a
exception.
huge saddle embolism.
Yeah. Okay. We had a caller from Worthington. This person said they got sick and was sweating profusely and nauseous. This happened a couple days ago. Chest tightness and short of breath. Wondering if it's something they ate or if it could be heart related, and they have a heart history. What would you tell this person if they called your clinic, Andrew?
I would ask them to come in to get evaluated.
I would ask them to go to the ER.
So, it could be an infection. It could be COVID. It could be some other infection. It could be a heart attack, certainly.
It could be a
and
pulmonary
it
embolism.
could be a blood clot in the lung. So that's why you'd want to get that checked out, because not necessarily let it get worse first.
Yeah, agreed. That's concerning. Dennis Hart was diagnosed with dementia in 2010, and in June of 2022 was moved to hospice. Ahead of that move, the Hart family discovered virtual reality, or VR, was part of the patient experience. Prairie Doc reporter Sam Schauer found out more.
Carolyn Hart, wife of Dennis Hart, was exploring hospice for her husband when she discovered VR at the Brookings Hospice.
At one point, all these different services started becoming available to us, including, as it turns out, the virtual reality system.
A VR headset gives the person wearing it an immersive 360-degree view of anything the person would like to see. For Dennis, it was sightseeing.
He'd comment about, the puppy, or he'd reach out to somebody, and in some of the scenes where there's people, he would talk to them.
Donna Buman, a hospice social worker at Brookings Health System, said a nurse had stumbled across VR being used in hospice. The nurse brought it up in a meeting, and the team loved the idea.
What we do with virtual reality is it gives our patients and their families an opportunity to escape sometimes the reality of their situation. So many people are stuck at home, and a lot of us have those bucket lists who never quite get completed. So virtual reality is a way to do some of those things that we didn't get to do, or for other people, go places that they've been and revisit things that they haven't seen for a while.
The VR system soon became one of the favorites at the hospice.
Every single person has loved it and said yes, they would like to use it again. So yeah, it's very well received. And there's a variety of things people can watch. It goes from puppies and kittens to skydiving and walking across deep canyons and watching Broadway musicals. So there really is something for everyone to be able to do.
Technology like VR has given hospice patients more things to do for entertainment.
So many of our people, they're confined to their quarters. It's usually pretty hard for them to even be able to get out of bed, let alone go do something. So this gives them a chance to escape for a little bit, do something different. So it really helps break it up.
For caregivers like Carolyn, it has helped her life just as much as it has for Dennis.
Anytime he's happier, it made our life a lot easier. And then to be able to have a quick virtual trip to Paris or Jerusalem or to the Rocky Mountains to see fishing, that was nice as a caregiver to have that mini getaway.
VR could be a look into the future for what hospices could become.
Hospice is a program designed to help people who have been determined to have 6 months or less left to live. So the to live part is the important part. There's a negative connotation with hospice that hospice is about dying. And we really want to get away from that. Hospice is about living right up until the end. And this is something virtual reality can help people do. You can have new experiences even if you're not able to leave the home.
So cool. Isn't that awesome?
yes.
Oh, I love it. More questions. Let's keep going. We've got a caller from Watertown who's wondering what the suggested treatment is for a fallen bladder. Deb, you want to take that one?
I can take that one.
Thanks.
So Dr. Kruse actually did a great show last season about this issue, but briefly, more common in women, far more common in women because of our anatomy and babies. Sometimes physical therapy can be useful. Sometimes a physical device called a pessary to kind of pull that bladder back in place. And then there's a bunch of surgical approaches. There is hope. If it's not symptomatic, if it's not bothering you, it doesn't bother me. If it's giving you trouble, there is hope. You don't have to live with it. See what we can do to help.
Yeah, and not everything is a surgery.
Not everything is a
people
surgery.
benefit from pessaries or for
Physical
certain
therapy.
PT. So
Yep.
okay. Andrew, we have a 70-year-old male who fell on his hip and was initially fine, but now is complaining of pain from his groin to his knee. He wonders if this could be a blood clot or something else.
Sure.
What would you say to that person?
Yeah, I mean, anytime you have trauma, an accident, I mean, there's possibility of a blood clot. Typically, you'd have swelling and pain there too. The swelling would be a bigger part of that. But with that injury and that pain down there, since it goes all the way down to the knee from the hip, I wonder if it's affecting a muscle, like maybe he strained a muscle or pulled a muscle. But you could certainly get that checked out. Maybe physical therapy might be helpful, or maybe it might just take some more time, perhaps. But
Right. And if it was yesterday and it's severe pain, I mean, a hip fracture certainly
still possible,
is possible.
I've seen
So
people walk on broken hips.
yeah. Okay. We have an almost 85-year-old male wondering if Prevagen, so some brand supplement that everyone sees their advertisements for, recommended to take for someone with a fading memory. Jill, you want to take that one?
You know, there's lots of things that say that they're going to help. How much research there is to back it up, I'm unsure. When the company selling the product is the only one that has the research for it, always makes me a little bit suspect.
Yeah.
So will it help? Hard to say. Will it hurt? Hard to say.
Yeah. Like so many things.
Like so many things. That
And
over
some
the
it's-
counter, it's not regulated by the FDA. So there's really not much that we get in our medical literature to back up any of their claims.
Some of these things are expensive too.
Yes.
Yeah.
Eat a healthy diet, lots of fruits, lots of vegetables, keep your brain active, keep your body active. Those are things that we know will help.
Right.
Yep. Good. We have a caller from Rapid City who comes from a family with medical professionals. Does wearing scrubs home from work contribute to infections, specifically COVID, but you could expound that to other infections? Andrew?
You know, I think there was a time when many of us, as soon as we got home, changed our clothes right away and gotten away from that some, I guess. But, you know, they've done studies. We knew from before COVID that ties were something that carried infections because they didn't get washed very often. But, you know, thankfully with scrubs, typically you're just wearing them to work and then hopefully you're just throwing them in the laundry to get washed again. But it is possible for germs to be on clothing. Now, we know from COVID specifically, it's more in the respiratory droplets. So we are less worried about it getting on things as we had been early on there.
Right.
Before we knew how it was transmitted, when we had so little information.
Yeah. Good.
I wouldn't worry too much about your husband or wife's scrubs coming home.
I wear mine home.
Yeah.
I do too.
Unless there's bodily fluids.
Unless there's bodily fluids on
Yes.
them, then I'll change into clean ones at the hospital. But that is a few and far between.
And you're in sterile, right?
Yeah.
Sterile.
We had a question, can the docs explain vascular Parkinson's disease? maybe I'm not understanding, but usually I think of those as two different things,
Yeah,
I guess.
like a
vascular
vascular
dementia
dementia.
being one thing, Parkinson's disease being a separate thing. Can you give a quick description of
So
both of those?
vascular dementia is usually related to small vessels in the brain that are getting blockages, and that can lead to a dementia that goes over time. Alzheimer's is a type of dementia that usually is related to amyloid plaque buildup in the brain tissue itself. So, people always ask, well, how do you diagnose Alzheimer's? Well, technically, the only true way to diagnose Alzheimer's is on brain autopsy, so we don't do that on living patients. Vascular dementia can be seen, those microvascular changes can be seen on CT scan. Very, very common. Actually, the cause of the dementia in my grandmother. But they can look very similar.
And Parkinson's disease is usually different, right, Deb? How does that look different?
Parkinson's disease usually it can have dementia associated with it, but usually that's later in the process. So Parkinson's disease, although it is a neurologic process, the first symptoms are more of a movement disorder. The tremor, the hesitation with walking, the abnormal gait, the tiny handwriting. So usually that's a different process and usually by the time they get to dementia, they've got Parkinson's.
You could have
in the
both
first
things
place.
at the same time. That'd
Absolutely.
be possible. But we have a caller from Rapid City who has a trigger finger, started locking up and is painful to use. It's currently in a splint and they're doing therapy. Is there anything else that this person can do for their symptoms, Andrew?
Well, they could watch our show from last year on ortho, and we focused on the hands, but it was a great show, I thought. But anyway, a lot of times trigger finger actually can be solved with a simple surgery, and so if you pull it in, it gets stuck, and so there's you've got basically cords going down to your muscle in your arm, and so then those can get stuck on the pulleys. Is one way to explain it, and so they can release that and let it go loose again.
Yeah.
So
if it's bothering them enough, reasonable.
but you don't have to worry about it.
Yeah. We have a caller from Ethan, South Dakota, wondering what can be done to treat snoring. Jill?
All right, so probably the easiest thing is losing weight, which is the hardest thing. But when we're talking about snoring, usually it's due to tissue in the back of the throat that's vibrating when you're sleeping. Elevating the bed, having a bit of an incline can help. Those nasal strips help somewhat. CPAP will get rid of snoring because you're forcing those airways open and not letting them vibrate. There's some ENT surgeons, especially if you're having sleep apnea with it, sometimes removing part of that soft palate, and the uvula can also help with the snoring. Obviously not the first thing you jump to, but weight loss would be the least invasive way to probably fix snoring.
And making sure that snoring can often go along with sleep apnea, which is a problem that is a bigger problem than snoring itself. So asking the question, could you have that, probably.
And sleeping on your side can help compared to on your back.
Versus back,
Good. Deb, how about what can we do to treat Bell's palsy, a caller from Sioux Falls?
Oh boy, that's a tough one. So Bell's palsy is a condition where we usually think it's a viral infection in the nerve in the face, and then people will end up with paralysis in one part of the face. So one thing that's important is making sure to take care of that eye. If the eye doesn't close very well anymore, then you have to worry about it drying out. And so there's that very practical point. Most people's Bell's palsy improves over time. There's some data about steroids early on in the course, but most of the time it's kind of a matter of watch and wait.
Good. All right, just a few minutes left. We have a caller from Sioux Falls wondering about warts and moles. She's 83 and in good health, but has more warts on the left side of her body, and wondering what the possible reason for this may be. Maybe not warts,
It might not be.
Yeah.
It could be from sun exposure over time causing some skin cancer, perhaps. So you might want to get it looked at. Some early skin cancers and warts, sometimes we'll treat with cryotherapy, freezing them, but maybe you might need a biopsy or have it taken off or get it looked at anyway, probably.
It might just get it looked at. Some things that look like warts in older people are the seborrheic keratoses too, that are very common, and your doctor might just look at those and be able to say nothing to worry about. Caller from Huron wondering why insurance won't cover post-COVID symptoms, and I guess that would be dependent on so many factors, and I don't know if we're going to have a solid answer for that. I'm sorry if you're having problems with that.
And remember, people with insurance, they have your money, they mean to keep it.
Yeah, painful. We share your pain. A caller from Harrisburg wondering if any side effect of the COVID-19 vaccine could be a loss of range of motion in that arm over a year later.
Certainly we haven't seen that very often at all. It could cause an inflammatory effect. Some people have had temporary swelling. If that's what someone's experiencing, that's what they're experiencing.
Yeah.
But,
Shoulder problems are such a common
Right.
thing.
Rotator cuff.
Yes, the shoulder is a not well-designed joint, and it's really, really common to have mobility issues, and any kind of an injury can cause issues on down the road. So I don't think we've seen a spike in that since people have been getting their vaccine.
Yeah.
I certainly haven't seen any more in my clinic than I saw before.
Right. Nothing certainly specific to the COVID-19 vaccine.
Right.
I mean, unless there was actual mechanical damage from the shot itself. But
Which I wouldn't think would show up a year later.
yeah. All right, 1 minute left. We've got a caller from Aberdeen wondering what can we do for osteoarthritis. Jill?
Strengthen the bones.
Yeah.
Yep. So work on pain control, and bones get stronger by activity. So it's kind of a use it or lose it. If you sit too much, they're going to rust. But listen to your body. If it hurts, stop. So anti-inflammatories, Voltaren gels, one of my favorites that you can get over the counter. It's because you can put the medication right where it hurts, and that can help with things. So talk with your doctor. Naproxen's also good because it's a once-a-day anti-inflammatory that you can take. It's pretty easy on the stomach.
Yeah.
But not everybody should take NSAIDs.
Yeah.
But not
Tylenol.
everybody, yep.
Tylenol is a good option too.
Yeah.
Yep,
Yeah.
very safe.
And sometimes
Few
it depends
interactions.
on what joint it is, right? If it's an osteoarthritis of this tiny little joint, harder, maybe less options than of the knee, in which you might have injections as an option, obviously surgery as a last resort. So.
And it is amazing some of the other joints that they're starting to replace, and that can really help some people.
Wrists,
So.
thumbs.
Yeah, great. Common problem. The winner of our prize tonight is a caller from Britain, South Dakota. Could you call back with your phone number next Thursday evening? We didn't get it. Thank you for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this.
Miss an episode or looking for a specific topic? Head to our YouTube channel or website, prairiedoc.org, today to access all On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB and Facebook for new shows.
For most people, taking a daily 81 milligram aspirin to prevent stroke and heart attack is more risky than beneficial. Aspirin has been in use as a pharmaceutical for over 150 years, making it one of our oldest. One might assume with all this experience, we would know exactly how to use it. But today's recommendations are based on better evidence gained from better science. Originally used to treat pain, aspirin evolved to become a cornerstone for cardiovascular protection after compelling research in the 1970s. By the 1980s, it was recommended that almost anyone over the age of 50 take an 81 milligram aspirin because it makes your clotting cells slippery, thus preventing clots from forming in your arteries of the brain and heart. Even at the 81 milligram dose, bleeding is aspirin's most common side effect. Physicians have long accepted this risk, however, as multiple large-scale research studies have established this risk is low and outweighed by its great benefits. This risk versus benefit relationship has been called into question by more recent research, leading to the recommendation several years ago that only those with highest risk of stroke and heart attack should take a daily aspirin. This includes people with diabetes, hypertension, and those who've had a stroke or a heart attack in the past, as well as those who may have stents in their coronary or other arteries. Research recently published in the April 2022 issue of the Journal of American Medical Association is a game-changing analysis confirming the benefits of aspirin are indeed outweighed by the risk of bleeding, specifically among those who have never suffered a stroke or heart attack, nor have a vascular stent. 1 out of every 250 people in this category taking an 81 milligram aspirin for 10 years successfully prevented a stroke or heart attack, but 1 out of every 200 suffered a major bleeding event. In an update to their 2016 recommendations, the U.S. Preventative Services Task Force now discourages using aspirin for the primary prevention of stroke and heart attack in adults over the age of 60. To clarify, those who have had a previous stroke or heart attack and/or have a vascular stent benefit greatly from a daily aspirin, and this benefit outweighs the risk of bleeding. There are exceptions to every rule and guideline, so please, as always, consult your personal physician regarding your unique situation and use of aspirin.
Thank you to Doctors Ellsworth, Johnston, and Kruse, our Prairie Docs, for volunteering their time to help us answer your questions. If you would like to see and hear more episodes of this program, please like and follow us on Facebook and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
As we age, how do we enhance our quality of life, optimize opportunities for health, participation, and security? Active aging, growing into your age, next time On Call with the Prairie Doc. Health information based on science, built on trust.
Mom, can you believe we are already entering the 21st season of On Call with the Prairie Doc?
It's amazing. Last year was so fun celebrating our 20th season. It was great to see the old shows and to just highlight the honest science and trust that our program is built on and that Dad started so long ago.
Yeah, and to see how it's grown. You know, to see it's not just a television program that you can find on Thursday nights at 7 o'clock, but it's something that you can check out on one of your favorite podcast networks or YouTube. Share these videos to your friends and family on Facebook.
There's a lot of ways that Prairie Doc is making an impact. We know it wouldn't be possible if it wasn't for you, our viewers, and for our corporate sponsors and our private sponsors. We are completely privately funded foundation, so your contributions make a difference. And did you know that a couple of years ago, the South Dakota Department of Health asked us to do some special programming that they felt was important for the whole state to know. We felt really honored that they would ask us to be a part of that. So you donors, you helped in providing good education for the state.
You know, as a nurse, one of my primary responsibilities is to advocate for my patients. And this program really allows our Prairie Docs, as well as the volunteer doctors, to advocate for public health across our state and into the surrounding states as well, which makes it particularly nice when a patient will come up to me and tell me that they really enjoy the program, or my parents watch your show every week.
Yeah, I hear that a lot, and it really is humbling and gratifying.
Yeah, and I'm excited and humbled to be joining the Healing Words Foundation board as we work to make an impact on the lives of our supporters and to further that mission.
If you would like to help us with this important work, we hope that you'll talk to your friends, you'll share our program on your social media page.
And if you want to make a financial gift, please give directly at prairiedoc.org or mail your gift to the P.O. Box 752, Brookings, South Dakota 57006.
Thank you for your support.
All right, Mom. You ready to go for a little walk?
You bet.
Let's get those steps.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
and with the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, South Dakota Academy of Family Physicians, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Vance Thompson Vision, Monument Health, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Yankton District Medical Society, Orthopedic Institute, Lake Poncet Sailing Academy, Aberdeen Asthma and Allergy, Dakota Bank, South Dakota American College of Physicians, and Swiftell Communications.